On behalf of Cambridge Health Tech Institute's Global Web Symposia Series and our sponsor for today's event, Biomodels, I'd like to welcome you to Preclinical Models of Lung Inflammatory Disease. My name is Elizabeth Leah, and I'll be your host and technical director for today's event. I'd like to introduce our presenters for today's webinar. They are Dr. Stephen Arrold, scientist and pulmonary lead at Biomodels LLC, and Dr. David Weinstein, president and COO at Numera. So with that, I will pass the presenter ball over to our first presenter, Dr. Arrold. The ball is yours. Welcome.
Thank you, Elizabeth. So I think you all know today that we'll be talking about preclinical models of inflammatory lung disease. We have a lot to cover, so I think I'm just going to get right into it. First, a little bit about our organization. Biomodels is a preclinical contract research organization. We're located near Boston, Massachusetts, in Watertown, Massachusetts, actually. We were founded in 1997 out of the Brigham and Women's Hospital. We design highly translational models of human disease and conditions for a wide variety of clients, ranging from big pharma, startups, academia. We have currently facilitated 37 compounds in the patients for multiple indications, and our therapeutic expertise is within pulmonary, oncology, inflammation, cardiovascular, neurobiology, fibrosis, and cancer supportive care. Later in the talk, I will be turning it over to Dr. Weinstein from Numera. He'll present some of the micro-CT imaging done by Numera and our mouse lung fibrotic models. Now that we have that out of the way, the scientific objectives of this talk, I'd like to discuss the application of 3 clinically relevant models of lung disease. We want to describe how these models can be effectively applied to assess the potential clinical efficacy of novel compounds. And while we develop models of biomodels, we're always remembering that the value of the model lies in the quality of its predictions. Our talk will consist of 4 parts. First, I'll discuss translational endpoints in pulmonary inflammatory disease. That includes measure of inflammation in the bronchoalveolar space. Also, some translational measures of lung function, endurance. Then we'll actually delve into the animal models, where first we'll characterize inflammation in airway hyperreactivity. 3 models of allergic asthma. We offer the ovalbumin, ova, house dust mite, and cockroach allergy models of allergic asthma. I'll then move on to models of acute lung injury, or ARDS. Currently offer a lipopolysaccharide, or LPS model of induced lung injury, as well as a hydrochloric acid-induced lung injury model. Finally, I'll wrap it up with a characterization of some of our mouse models of pulmonary fibrosis. We currently offer the bleomycin-induced fibrosis, both IV and IT, and we have a radiation-induced lung fibrosis under development. So that brings us to the translational endpoints in pulmonary inflammatory disease. Let's start with translational modeling. What do we really need to establish to have an effective translational model? Obviously, the model must replicate the clinical condition. The underlying biology should be the same, or as close as we can make it to human pathology. Ideally, the model is cost-effective and provides actionable information. And really, most importantly, we need the endpoints that should be translatable to those used in clinical trials. I think some of the people here are probably aware that hundreds of investigators have cured tobacco smoke-induced inflammation in mice. But if that data doesn't translate to the clinic, it's just really been only a costly exercise. So what we want to look for are these preclinical models able to predict if your molecule or therapeutic will really hit your endpoints in the clinic. For example, we can start here. We have 3 tables from the literature reviewing clinical endpoints of human trials of inflammatory lung disease. We have COPD, idiopathic pulmonary fibrosis, IPF, as well as asthma. Of course, biomarkers is listed and is really one of the favored outcomes in preclinical studies, both because of its ease and its translatability, if that's the word. In the case of pulmonary disease, there are other outcomes that are actually more common in the clinic, but neglected in preclinical research. 2 significant outcomes that are almost always tested would include endurance testing, usually measured by a 6-minute walk or other endurance tests, as well as lung function. That's often measured in terms of vital capacity, airway caliber, airway resistance, and lung compliance. I'll discuss most of those in more detail shortly. So how do we measure biomarkers in pulmonary preclinical research? because of the unique physiology of the lung, we can really employ the bronchoalveolar lavage to measure inflammation in the bronchoalveolar space. In this case, in the mice, the lung trachea is cannulated. We can wash the lungs with PBS. In our case, we generally use 5 times 0.5 mils. Then we have the lavage fluid that we can spin down for total cell counts. We can look at differential cell counts. And we can also save the supernatant and measure inflammatory mediators or total protein. So, for example, on the right, we have the BAL differential slides from a naive mouse. And really all you see is your occasional unactivated macrophage. On the right, you can see the BAL from an LPS-challenged mouse, and it's dramatically different. You can see we still have some of the macrophages present, but we have significant neutrophil influx into the lavage fluid. And actually, in this case, you can also see some red cells in there as well. Histology can also be an effective way to measure inflammation as well as changes in lung structure. Here you can see a Mason's trichome stain from one of our naive mice, and you can compare that to Mason's trichome in one of our bleomycin-challenged mice. I think it's pretty obvious that there's a significant change in fibrosis, and there should be a significant change in lung function in this mouse. And as always, we can look at inflammatory biomarkers in the serum. So this brings us to lung function and lung mechanics. There are a number of ways, methodologies out there to measure lung mechanics in small animals. Jason Bates summarizes these relationships as the phenotyping uncertainty principle. It's close to the Heisenberg uncertainty principle in quantum mechanics, but here you really have a gradient of precision in measuring lung mechanics at the expense of invasive techniques. So on the left, you have the least precise, but at the same time, the least invasive measure of lung mechanics, and that would be unrestrained plethysmography. You have freely moving animals inside a closed chamber. It's effective at measuring breathing frequency, tidal volume, but that's really where the utility ends. There is an enhanced pause that some people like to use, but I think it's kind to say that that's at the very least a scientifically dubious method for measuring lung mechanics. In the intermediate, you have restrained plethysmography. This would include 1-chamber or 2-chamber plethysmography in mice. In this case, you have to restrain animals, so it is a little more invasive. You can make more important measurements or more relevant measurements that include airway resistance, but you're still relying on a spontaneously breathing animal, and all these measures of lung mechanics are effort dependent. On the right, and the most precise yet the most invasive technique, we have forced oscillations. This includes the use of anesthetized, tracheotomized, ventilated animals. It is the most precise measure of pulmonary mechanics available, but as I mentioned before, it's at the expense of invasive techniques. Here at Biomodels, we use the flexiVent mechanical ventilator to do our lung mechanics testing. In general, the mice are anesthetized, tracheotomized, and we put them on the flexiVent computer-controlled rodent ventilator. In addition to ventilating the animals, it allows for ventilation of the mouse and forced oscillations. We can make pressure volume curves, broadband forced oscillation, and we can do nebulized methacholine challenge in these mice. First, let me describe the pressure volume curves. The flexiVent can apply quasi-static increase in lung volume or pressure at the airway opening. So it measures increases in air pressure as a function of lung volume. So on the bottom left, you can see, for example, the pressure volume relationship of one of our naive mice in black as opposed to one of our bleomycin-treated mice in red. You can see that bleomycin, it's known that it induces fibrosis in these animals, and this results in a rightward shift in the pressure volume curve. Clinically relevant outcomes we can get from this measure is lung compliance and elastance. Compliance is just the curve of the ascending loop. Elastance is the inverse of compliance. We can measure vital capacity, which we can define as lung volume at 30 centimeters water. And we can look at work of breathing, which is the area under the inflation curve. Lung mechanics, we can look into forced oscillations. I originally designed the slide. I had a good deal of complex mathematics and calculus. My colleague suggested that maybe I should take that out. May bore you, and focus on really the bottom lines. So what we do here is we can apply forced broadband oscillations at the airway opening. We measure pressure and flow, and we apply complex analysis that the constant phase model specifically to look at central airways and peripheral changes in lung mechanics. Our outcomes here are airway resistance, resistance to central airways. This is very relevant to changes in lung function during allergic asthma. And we can also measure tissue elastance and tissue damping. These are essentially relevant to changes in lung function during acute lung injury, where we see stiffening of the lung, or COPD, where we see loss of elastic recoil. Finally, I'd like to get to the methacholine challenges that we can do in the flexiVent. And what I'd like to point out here is this is airway resistance measured through forced oscillations as a function of time. And the flexiVent can nebulize methacholine, or at the starting point here, saline, into the inspiratory tract. So here, the animal is ventilated with pure saline. We see very little change in lung mechanics. And at this point, we hit the animal with 12.5 mg per ml of methacholine. You can see there's a bump and a decline in airway resistance. As we continue to increase the dose, we can see that there's an increasing dose-responsive increase in airway resistance, where it goes up, comes back down. And if we look at this relationship in OVA-treated mice, we see it's exacerbated. Treatment with a corticosteroid, dexamethasone, reduces this effect. Just in the bottom here, we have the population averages. Also, what we do at Biomodels that I think is a little unique, we also do endurance testing. For this test, we primarily use wheel running. Here you can see the daily running distance as a function of time for some mice in our radiation-induced fibrosis model. You can see that the distance the mice run fall off during the acute inflammatory phase, and it will start to recover thereafter. We use this as a surrogate for the 6-minute walk that is extensively used in the clinic. We also have a forced exercise measure under development. So that brings us to the animal models, where we're characterizing inflammation and airway hyperactivity during allergic asthma. Human asthma is characterized by reversible airways, narrowing of hyperresponsive airways, chronic pulmonary inflammation. In humans, this is eosinophilic as well as neutrophilic, and remodeling of the asthmatic airway. Currently, there are more than 25 million cases in the U.S. alone, and this results in a direct or indirect cost of greater than $18 billion per year. Treatment in allergic asthma usually consists of an anti-inflammatory and long-acting bronchodilator. At Biomodels, we offer 3 models of allergic asthma. We have the OVA model, house dust mite, and cockroach allergen model. In the OVA model, we sensitize the animal's IP with an OVA adjuvant mix on days 0 and 7. And this is followed by intranasal challenge on days 13 to 15 in our acute model. We can extend this model or customize it based on the need. We also have the house dust mite, where these animals are sensitized by intranasal administration now on days 0 and 7, followed by a challenge on day 14 in our acute model. We also have the cockroach allergen model, where the animals are sensitized via intratracheal instillation on days 0 and 14, followed by IT challenge on day 21. Our endpoints here will be total and differential cell counts in the BAL. We'll look at detailed lung mechanics with the flexiVent, inflammatory mediator content, as well as histopathology. And our treatment routes for compounds include intranasal, intratracheal, the microsprayer, nebulized IV, sub-Q, IP, as well as oral gavage. So here's one study design for the OVA model. Again, these animals were sensitized on days 0 and 7, and then challenged on days 13, 14, and 15. We did treat some of these animals with a positive control, in this case dexamethasone. And generally, dexamethasone or test article treatments can generally be between days 12 and 16. Endpoints on day 16 in this study included BAL as well as airway hyperreactivity. Here you can see we saw a dose-responsive increase in total inflammatory cells at 20 and 200 micrograms of OVA. This was primarily eosinophilic inflammation. When we treated these animals with dexamethasone, we saw a very significant decline in inflammation, and that held in the BAL fluid. And as you can see in the histology, we saw a reduction in inflammatory cells primarily around the airways. And this was eliminated with dexamethasone treatment. Here with lung mechanics in the OVA model, I showed you some of this data before. Again, the animals were on the ventilator, and then they were challenged with 0, 12.5, or 25 mg per ml of methacholine. And at the top here, you can see airway resistance. I've now added tissue elastance, and the population averages are on the bottom. You can see that in the OVA-treated mice, we saw a significant increase in airway resistance in comparison with naive controls. This was reduced to some extent with dexamethasone. And in the case of tissue elastance, we saw a very hyperreactive relationship with OVA that was almost completely eliminated with dexamethasone. That brings us to our house dust mite model of allergic asthma. Here, the sensitization and challenge regimen was as I described earlier. Briefly, they were sensitized intranasally on days 0 and 7, and then challenged on day 14 with 25 micrograms. And the endpoints were measured on day 15. Here you can see that we saw a significant increase in inflammatory cells in the BAL, total inflammatory cells. This consisted of increases in eosinophils as well as neutrophils. And you can see that all these relationships were reduced with dexamethasone treatment. I'm not going to present the airway hyperreactivity data in house dust mite because it follows the OVA, and the OVA and house dust mite models are very similar. So at this point, I'll summarize what we have in terms of our allergic asthma models. We have 3 models of allergic asthma here at Biomodels. The OVA model really is the most traditional model in the literature. It recapitulates most of the hallmarks of allergic asthma as a primarily eosinophilic model. It's the most characterized allergic asthma model. And the house dust mite and CRA might be more physiologically relevant. They don't require adjuvants. They are delivered via a more relevant administration route, the respiratory tract, as opposed to IP administration. And neutrophils are also present in that disease. The duration and sensitization in all these models can be customized to fit the therapeutic application. And in these models, we generally use dexamethasone as a reliable positive control. There was one question about how we analyze the BAL. In general, we aliquot all the BALs together for total cell counts, but we'll save the first or second BALs for inflammatory mediator analysis. That brings us to the next section, mouse models of acute lung injury, or ALI, as well as acute respiratory distress syndrome. So ALI is characterized by hypoxemia, pulmonary edema, low lung compliance or increased elastance, and widespread capillary leakage. It's actually defined, acute lung injury or mild ARDS is the less than 300 millimeters of mercury fraction of arterial oxygenation to inspired oxygenation. And ARDS is obviously more severe at 200. In general, it affects about 175,000 Americans annually, and it really has an unacceptably high mortality rate of 30 to 40%. Some of the common causes: pneumonia, sepsis, aspiration, trauma, and in humans, this generally requires mechanical ventilation, which also increases the risk of ventilator-induced lung injury. At Biomodels, we offer 2 models of acute lung injury. We have the hydrochloric acid installation model, where we deliver between 50 and 75 microliters of 0.1 normal hydrochloric acid intratracheally. Generally, those models last between 1 and 96 hours, but we are able to pull those out further. LPS-induced lung injury, generally we like to deliver this intranasally. We can do intratracheal administration as well. And the length of this model can be anywhere from 4 hours, and I just recently finished a study that lasts up to 7 days. Endpoints in these models are similar to the allergic asthma models, and the treatment routes are generally the same. So first, I'll present some data on our hydrochloric acid-induced acute lung injury model. This was a very basic setup. We challenged the mice at 0 hours and looked at endpoints 24 hours later. That was just an IT administration of a dose response of hydrochloric acid. And 24 hours later, we looked at cell counts, total protein, as well as lung mechanics. So here are outcomes. First on the left, you can see total inflammatory cells increased in a dose-responsive manner up to a significant increase at 75 microliters. In all these cases, it was almost completely neutrophilic inflammation. So we saw a significant increase in neutrophils, even at the low dose. And we saw increases in total protein, which reflects the leakage of plasma proteins into the alveolar space. This generally correlates with pulmonary edema in humans. The lung mechanics during hydrochloric-induced lung injury. Here we can see the pressure-volume relationships. In pink, we have the naive animals, and in the colors, we have the hydrochloric acid. And you can see at the low dose, we see a slight rightward shift in the pressure-volume curve. This is exacerbated with increasing amounts of hydrochloric acid. And if we measure lung mechanics from the pressure-volume loops, we can see significant increases in lung mechanics at the mid and high doses. So in general, we like to use the high dose of hydrochloric acid. For the LPS-induced lung injury model, If you're not aware, LPS is an endotoxin. It's present in the outer membrane of gram-negative bacteria. LPS induces a TLR4-mediated inflammatory response. It serves as a good model of the host's innate immune response. And LPS-induced lung injury often serves as an acute screen for chronic neutrophilic inflammatory diseases such as COPD. So in the data I'm going to present now, we challenged the animals with LPS at time 0 and looked at the response 24 hours later. This was from LPS from Pseudomonas. In general, in this model, we can deliver positive control or test articles between an hour before, 24 hours after, and the endpoints. So here in this model, we see as you go from naive to 1 to 10 micrograms of LPS delivered intranasally, we see a dose-response increase in total inflammatory cells. Very, very highly significant increase here. Again, this is primarily neutrophilic inflammation, and we do see some increase in total protein. Now, when we increase up to 100 microliters of LPS, we see a little bit of a decline. This is actually in total cell counts. This is actually pretty well established in the literature, but we still see a significant increase in total protein. And you can see from the histology as we increase the LPS amounts, we see more infiltration of inflammatory cells. In general, because of this relationship, we like to treat the animals with the peak response, so we'll titrate each new lot of LPS that we get in at Biomodels. I'd like to just present the time course of acute lung injury from LPS. In this case, they were dosed with LPS at time 0, and we looked at inflammation at 24, 48, and 72 hours. In this case, you can see that as time progressed, we saw increases in total inflammatory cells before 24, peaked at approximately 48 hours, and it looks like this inflammatory response started to resolve after 48 hours. We see the same pattern with neutrophils, and in this case, we actually looked at IL-1 beta, and it appears that it follows the same pattern. In terms of lung mechanics, the increases in elastins generally reflect changes in inflammation. We can see at 4 hours there wasn't too much of a change in lung mechanics, but as we continue to 24, and particularly 48 hours, we see a more dramatic rightward shift in the pressure volume curve. This is really reflecting an increase in lung stiffness as a result of edema and pulmonary inflammation. And again, you can see that this starts to resolve after 72 hours. When we quantify this in terms of lung mechanics, again, lung elastins peaks approximately 48 hours and starts to resolve thereafter. There is a question, what is the mortality rate in each of these models? Generally, 10 micrograms of LPS delivered intranasally, we see a 0% mortality. Up around 100, we will start to see some animal deaths. Kathleen asked about positive controls in this model, and that brings us to a study where I do want to present some positive control data. Again, in this case, we did an intranasal administration of LPS under ISO. We used 10 micrograms of LPS, and the animals were dosed with dexamethasone once a day at 0 and 24 hours. We collected the endpoints in this example at 48 hours or peak inflammation. And here are inflammatory endpoints. You can see that after 48 hours in the LPS-only group, we saw a very significant rise in neutrophils, almost 6 million cells. Treatment with dexamethasone severely reduced the amount of inflammation significantly. And in this case, we looked at IL-6 and IL-1 beta again, and we saw that the cytokines generally followed the inflammatory cells. At the bottom here, you can see some of the histology results. We have the naive cells, 2 LPS treatment. You can see severe inflammation, a lot of inflammatory cells here. And this was, to some degree, reduced with dexamethasone treatment. Our LPS, our positive control, we looked at lung mechanics and pressure volume curves here. And on the right, you can see, again, LPS induced a very significant rightward shift in the pressure volume curve, and this was almost completely eliminated with dexamethasone treatment. So to summarize our acute lung injury models, we have 2 validated clinically relevant models of acute lung injury ARDS. The hydrochloric acid-induced model, it replicates necrotic insult to the pulmonary epithelium. This would be inhalation toxicities, aspiration of the stomach contents. The LPS-induced model simulates more of the innate immune response. This would be a pneumonia or sepsis. We characterize both of these models with regard to lung inflammation, histology, cell counts, and cytokines, as well as detailed lung mechanics. And in these models, dexamethasone serves as reproducible positive control for the testing of anti-inflammatory compounds. So this brings us to the final section, fourth part, where we're going to characterize some of our mouse models of pulmonary fibrosis. So first, a little bit about pulmonary fibrosis. It's a progressive fatal lung disease characterized by irreversible loss of lung function, ultimately death. Pulmonary fibrosis can be idiopathic in nature. It can arise from radiation therapy or even to some degree following acute lung injury or ARDS. It affects approximately 128,000 people per year in the United States and has an approximate median survival of 4.2 years. Currently in the United States, there are no FDA-approved treatments at this point. Pirfenidone has been approved in the European Union and Canada and has met some recent phase 3 success in the United States. So I think the expectation is it will be approved. And also nintedanib has demonstrated also some very positive phase 3 results. So a little more background on pulmonary fibrosis. I think it's considered to be a TGF-mediated fibrotic pathway. It's been characterized as a communication failure between the epithelium and the mesenchyme. It really results in chronically activated fibrotic pathways, and this results in excessive collagen deposition by myofibroblasts that results in fibrosis, scarring, and leads to degradation in lung function. You can see the CAT scan on the left of a human with IPF. You see significant honeycombing, and this is also present in histology, where you can see both very dense fibrosis as well as some of the honeycombing that you see in the CT scans. So we have 3 models of pulmonary fibrosis, 3 animal models of pulmonary fibrosis at Biomodels. We have an intravenous bleomycin-induced pulmonary fibrosis. In this model, it is bleomycin is introduced intravenously for 5 days. The endpoints in this model are generally 42 days. We have an intratracheal bleomycin-induced pulmonary fibrosis. In this case, there's only one delivery of bleomycin, and that's delivered to the lungs via intratracheal intubation. In general, that's a 21-day model. And we're also bringing online a radiation-induced pulmonary fibrosis. In this model, mice are irradiated with a single dose, generally between 14 and 20 grays, delivered to the thorax. And this is a more chronic model that can last up to 20 weeks. In this case, the endpoints are similar to the earlier models. We look at histopathology, fibrosis scoring. Again, we can look at detailed lung mechanics with the flexiVent. We always look at hydroxyproline content. We can look at the inflammatory cells, inflammatory mediators. In this case, we're going to present some micro-CT imaging of bright tissue content by Numera. And we can also do endurance testing or wheel running, which would really be indicative of the 6-minute walk. And the treatment routes in this model generally follow. So first, our IV-induced pulmonary fibrosis model. Mice will get IV doses of bleomycin at days 0, 1, 2, 3, and 4. The endpoints in this model are in day 41. And generally, we'll follow body weights and respiratory status throughout the study. On the bottom left, you can see some of the weight changes in these animals. And you can see this model results in significant weight change, weight loss, that is generally dose-dependent. In this slide, we're looking at lung weights, lung collagen content, and the modified Ashcroft score in the IV model. As you can see here, lung weights increase in a dose-responsive manner. Lung collagen generally does the same, and the Ashcroft scores follow also. For the intratracheal-induced pulmonary fibrosis, again, this is only a single administration on day 0. Our endpoints are on day 21. And in this case, we also see weight loss, a milder weight loss in these animals, but interestingly, it's not dose-responsive. And again, in these animals, you can see naive animals compared to bleomycin-induced fibrosis. We see some fibrotic areas and inflammation in these models. Here we have lung weights, collagen content, and modified Ashcroft score for these same animals. And in general, you see a little bit of a dose-responsive increase, but with these measures, we do see what appears to be a peak fibrotic response in this model. And much like the LPS, at Biomodels, we will titrate bleomycin dose with each new lot that comes in for validation. So our next step, we wanted to look at pirfenidone and an anti-TGF-beta treatment in a mouse model of pulmonary fibrosis. So the first question was, how does bleomycin-induced fibrosis impact lung mechanics? And do these treatments alter changes in lung function? How does the standard of care, pirfenidone, influence development of fibrosis and changes in lung mechanics in a mouse model of fibrosis? And can we slow the development of fibrosis by inhibiting the TGF-beta fibrotic pathway? So in order to accomplish these goals, we put together our IT model. We had 4 groups of 8 animals each. 3 of the groups were dosed with bleomycin. We had 1 naive control group for comparison. The naive group was untreated. There was 1 bleomycin exposed group that was untreated. And the 2 final groups were treated with either pirfenidone, PO, at 100 mg per kg dose or 200 mg per kg daily, or an IP delivery anti-TGF-beta at 3 mg per kilo. I should also point out that this dosing schedule did start on day -1, so before the induction of fibrosis. Our endpoints here were animal weight change, detailed lung mechanics with the flexiVent, micro-CT of whole lungs, histology, both at H&E and Mason's trichrome. We wanted to look at the fibrotic index, the percent affected, and inflammation scoring. And we also looked at hydroxyproline. Here are results from our animal weights. You can see in our bleomycin-only treated model, or group, we saw a mild reduction in mouse weights. This, to some degree, was ameliorated with TGF-beta, anti-TGF-beta treatment, or pirfenidone. Here's some representative histology slides in this study. At the top left, you can see naive animals, healthy lung. To the right, you can see some fibrosis induced by bleomycin treatment. And in the bottom left and bottom right, you can see anti-TGF-beta and pirfenidone treatments, respectively. You can see, at least in these examples, both pirfenidone and anti-TGF-beta treatment seem to reduce the development of fibrosis. If we want to look at the Ashcroft scores, percent affected, and hydroxyproline content in these animals, we see that the Ashcroft score increased significantly with bleomycin treatment in comparison to naive animals. Pirfenidone significantly reduced the Ashcroft score, as well as anti-TGF-beta treatment. If we want to look in terms of affected areas, again, bleomycin induced an approximate 12% affected area, and this was significantly reduced with pirfenidone and reduced with anti-TGF-beta treatment, but not significantly. You can see hydroxyproline followed the same trends. Here are the representative pressure volume curves in the naive animals, bleomycin treated in both of our treatment groups. On the left, you can see the anti-TGF-beta treatment. As you can see, bleomycin induced a significant rightward shift in the pressure volume curve. This is a stiffening of the lungs as a result of the fibrosis. And when these mice were treated with anti-TGF-beta, this was almost completely eliminated. In terms of pirfenidone, this is actually a typo. This should be pirfenidone. Again, we can see pirfenidone slightly ameliorated the fibrotic response as a response to bleomycin. If you want to quantify lung function, we can see bleomycin resulted in a very significant increase in lung mechanics, lung elastance. Pirfenidone reduced this to some extent, but there was a significant reduction, almost to naive levels, with anti-TGF-beta treatment. If we want to look at this in terms of vital capacity, bleomycin had a significant reduction in vital capacity in these mice. This was improved somewhat with both of our treatments, but not significantly. Also, we can look at work of breathing. You can see bleomycin treatment induced a significant increase in the work of breathing, which was ameliorated with pirfenidone as well as anti-TGF-beta. And at that point, I'd like to turn things over to Dave Weinstein, who, in addition to these endpoints, will present some of the compelling micro-CT data demonstrating some of the changes in lung structure after bleomycin-induced fibrosis and treatments.
Great. Thank you very much, Stephen. Good morning, everyone. I'm just going to spend a minute here introducing Numira just to give you some context for the work that we did on this study. So just like Biomodels, Numira is a specialized CRO. What Numira specializes in is developing tools and technologies in order to provide more sensitive, more statistically powerful readouts for models like the one we're talking about today. Up at our Seattle facility, we provide specialized histology and 3D cell screening oncology services. At our Salt Lake facility, which is where I'm located, we focus on high-resolution 3D imaging and analysis, specifically micro-CT. So I'm going to show you a bunch of examples of those in just a minute here. By partnering with Biomodels, we're now able to provide these turnkey solutions in key areas such as renal fibrosis, inflammation, oncology, and as we're talking about here today, pulmonary fibrosis. When people think about micro-CT, usually they think about bone, harder structures. Micro-CT is an X-ray-based modality. So it's just like the CAT scanners that are up at the hospital that can image humans, but they're miniaturized. So we're imaging at about 6-micron resolution, very, very high resolution, and it's all ex vivo. All the imaging that we're going to be showing today is ex vivo. So on the left-hand side of this slide, you're seeing an example of a RA rat paw. So indeed, we can use micro-CT to image high-resolution bone structures. But the unique capabilities are at Numira are that we can also image the soft tissue structures. So in the middle, you're seeing a perfused rat brain. We've developed this ultra-blue perfusion reagent so we can look at vasculature. And over on the right-hand side, you're looking at some fibrotic mouse lungs. So this is a perfect example of the sort of data that Numira provided for this study in order to have an additional endpoint and, as I mentioned, a very, very sensitive endpoint. So with our micro-CT, as you're seeing these, so over on the right-hand image, there's those brighter regions within those lungs. Those are indicative of fibrosis. So on the next slide, what you can see is in addition to just acquiring the raw three-dimensional grayscale data, which is beautiful and, again, very high resolution coming out of these scanners, what Numira is also able to do is to quantify those results. So it's not just pretty pictures, there's metrics here, there's statistics, there's powerful mathematics that we can provide to our customers as part of our service. So on the left-hand side, we're looking at the surface roughness of this rat paw. In the middle, we're looking at the size of each of the vessels through the brain. And over on the right-hand side, what we're looking at is which pixels, or in 3D, which voxels are brighter, are hyper-attenuating, as we say. It turns out that those pixels are exactly the regions that you're seeing fibrosis within these specimens. And the power of being able to image in 3D volumetrically is that we see what's happening everywhere throughout the lung volume. So this is in contrast to, for example, a hydroxyproline measurement where you're just looking at collagen content through the entire lung volume. It doesn't give you any specificity in terms of, well, perhaps there was just one lobe that was very, very fibrotic or one patch within one lobe. You don't get that sort of detail, that sort of spatial information out of the chemistry measurement. Or if you're just looking at histology sections, which we do as well, you would have to take an infinite number of sections in order to capture what's happening everywhere throughout the volume. So for diseases that present heterogeneously, such as the earlier stages of fibrosis, it's very important to be able to see what's happening throughout the entire lung volume in order to understand what's happening in your animal model. And obviously we can do that with a three-dimensional volumetric imaging modality like ex vivo micros. When we do a study at Numira, we present the data back to the customers. We share the data with them through a cloud-based system that we call AltaNexus. AltaNexus runs up in Microsoft Azure Cloud, and it allows us to host very, very large data sets, very, very large studies, and allow our customers to look at and collaborate, securely share that data set as we're progressing through a study with them. So I encourage everybody to go check out that link. It's altanexus.com. There's lots of examples in there, including some marketing data sets from a pulmonary fibrosis study that you can look at. And in fact, this is that example study. So here's how data is presented within that system. You're seeing thumbnail snapshots here of a bunch of different data sets that were all part of the study. By clicking on any of those data sets, it pulls up more information about that specimen. It also pulls up live streaming movies. So this is sort of like Netflix. You can stream the visualization and go in and annotate structures and collaboratively share this data. So this system supports all sorts of imaging data as well as standard documents that are associated with the study like PDF reports, Excel spreadsheets, PowerPoints, all of that sort of stuff. So here are some data sets from this specific study. And what jumps out at you immediately is that the bleomycin model, the data set in there in the middle toward the left, has lots of brighter voxels. The stain that we're using for this study binds to connective tissue, and so once it has bound and then we put it inside of the imaging chamber for micro-CT, those regions get brighter. Those regions are hyperattenuating. And so what you see is with the naive specimen over on the left, there is some connective tissue just naturally within the lung. Obviously, that's being highlighted. With the bleomycin data set, lots of bright tissue. And then when treated with pirfenidone or the anti-TGFß, you see a greatly reduced burden of fibrosis. You do still have some patches there. So immediately, just looking at the qualitative, this is what we call a maximum intensity projection, so showing you all of the data, you can immediately appreciate the difference between each of these examples shown here from each of the treatment groups. Here's some of the metrics that you can immediately pull out when you analyze this micro-CT data. So as expected, there's lots more bright tissue associated with that bleomycin data set, actually the bleomycin group. So we analyzed all the specimens and then derived these averages here, in comparison to the saline or the treated groups. On this next slide, this is a typical type of analysis that we do on data sets like this. What we're looking at here at the top left and top right is a histogram. So for each of the grayscale values, going from black on the left to white on the right, we're showing the prevalence of that particular grayscale value. So for the 4 different groups that we're looking at, you can see significant differences between these histogram curves. Over on the top right, I've zoomed in on that brighter region of the histogram. So these are all of the voxels that are above a particular threshold. And what you can see is exactly what's going on in terms of how many bright voxels of different degrees you have within the data set. So the saline group, the control over on the with the blue curve, sort of at the bottom left, showing not nearly as many bright voxels, in contrast to the right bleomycin curve, which is above and to the right of it. And then you have these 2 groups in between, the treatment groups, showing very different curve types for the pirfenidone and the anti-TGFß. These are very good examples of the sorts of data sets that we're able to acquire with micro-CT. As I mentioned at the beginning, it's a very sensitive modality. So at earlier time points in the study, or when you have less severe disease progression, you're able to pick up these changes very early on using this micro-CT technology with the staining and imaging that we do here at Numera. And with that, I will pass it back to you, Stephen.
Thank you, David. Let me get my pointer back. And for our last data slide, I just wanted to present some of the correlations we have in this model. And it actually turns out that lung elastance, which we would interpret to be one of the more translational measures, is actually very well correlated with a lot of the traditional outcomes in pulmonary fibrosis in mice. Maybe not tissue volume, but here you can see lung elastance is highly correlated with the bright tissue volume that David just presented. And this is actually still highly correlated without this outlier over here. Probably more relevant to what people are used to is the correlation between the Ashcroft score as well as lung elastance, and these are very, very well correlated with a high significance level. And you can also see, if you want to look at some of the more functional lung mechanics measures, lung elastance is inversely correlated with vital capacity, which is exactly what you would expect. So the conclusions from this part of the study have shown that bleomycin administration results in a significant fibrotic lesions in the lung. We saw this with both histological and micro-CT analysis. These changes translated to significant functional alterations in lung function. We could look at elastance, vital capacity, work of breathing. Maybe a little more interesting was the treatment with TGF-beta neutralizing antibody as well as pirfenidone, significantly reduced the histological and functional changes induced by bleomycin challenge. And this data really supports the existing preclinical data or clinical data suggesting pirfenidone is effective at reducing pulmonary fibrosis. Furthermore, this might suggest that a TGF-beta neutralizing antibody may be effective in the treatment of lung fibrosis in humans. And I think that is actually in phase 1 currently. In terms of biomodels, we do have 2 very effective positive controls in this animal model. So kind of a broad summary, we presented translational animal models of 3 types of pulmonary inflammatory disease: acute lung injury, allergic asthma, pulmonary fibrosis. We've presented endpoints that determine efficacy in small animal models. We have clinically relevant endpoints that really are predictive of success in the clinic. Specifically, we look at biomarker and inflammation outcomes. We can look at lung function testing, endurance, and you can look at relevant medical imaging, which in this case was done by Numera. So I'd like to end here with acknowledging some of the people that did this work. Our senior scientific staff at Biomodels consists of myself, Dr. Sonis, Ling, Beal, Mancini, and Mina, as well as a lot of the technical staff that did this work downstairs. And I'm sure Numera would be happy to recognize the same people. I did want to address some of the questions that came up in the chat. There was a question, do we have a model of kidney fibrosis, or is this model relevant to kidney fibrosis? And the answer to that question is yes, we have a kidney fibrosis model here at Biomodels. The N per group actually in our fibrotic model was only 8, so it might have been a little underpowered, but it was a pilot. And our dexamethasone treatments were delivered IP in all of these treatment groups. And with that, I would be happy to take any more questions.
Thank you, Steve and Dave. Our first question is, what phase of bleomycin-induced fibrosis model would you select to start administering the therapeutic drug of interest?
That's actually a very good question. In this study, we initiated treatment at day -1, so 1 day before bleomycin treatment. And this might be a relevant treatment modality if you know you're getting radiation therapy, but in terms of IPF, if you're looking at IPF as an outcome, it might be more clinically relevant to wait for the fibrosis to develop. We've done similar studies to this where we initiated bleomycin treatment and waited till peak inflammation, which generally comes around day 6 or 7, and then induced treatment with test article or positive control. So the real answer to that question is it depends on your model and specifically what you want to look at.
Great, thank you, Steve. The next question, what model would best fit to test the efficacy of compounds for COPD?
COPD is a tough one. COPD, as I alluded to in the introduction, there's a mouse tobacco smoke model, which is very popular. It's a chronic model, so it takes more time. It's more costly. Unfortunately, it appears that the tobacco smoke model has caused a lot of false positives in terms of efficacy in mouse models. There are a lot of instances where there are very promising compounds that were developed in the tobacco smoke model that just failed in the clinic. We presented the LPS model of neutrophilic inflammation. You could use the LPS model with chronic insults of LPS to induce more chronic inflammation, or my suggestion to a lot of clients would be you use this as an initial screen to see if you can reduce neutrophilic inflammation. Maybe look at 24, 48 hours, and then go from there.
Thank you. And our final question today is, what is the typical turnaround time to run a study?
The typical turnaround time, this can vary, but essentially, as you can see in our label, we'd like to be fast. Once we have a approved protocol, generally my next action is to call downstairs and get the mice in-house. So generally we'd like to get the study started within 1, at most 2 weeks.
Great. And thank you again to both of our presenters. This wraps up today's presentation. Thank you to all of you who attended. As a reminder, next week you'll be receiving a copy of the recorded webinar. If we did not get to your questions, we'll be following up via email. And should you have additional questions for our presenter, feel free to email them directly at the emails that are listed on the screen. Thank you.